Prostate cancer is the most common cancer among men in the UK, with more than 40,000 new cases diagnosed in 2011. For men whose disease has spread beyond their prostate, the standard treatment has, for decades, been hormone therapy, with radiotherapy for those whose disease has only advanced just beyond the prostate.
The situation really hits you that there isn't a cure, you've just got to have some treatment. And the treatment, I was told, was the best. It sounded as if that was okay because you think you're having the best, so that's all you can do. But really, it was just hormone therapy, tapering down to when your PSA goes up again. And when that happens, you go on another drug, and you're really running out of time then, to put it bluntly. So the prognosis wasn't very good, and we were very, very in the depths of despair at that time.
In recent years, a number of promising new ways to treat prostate cancer have emerged.
So around 10 or so years ago, there were a number of new agents starting to appear in prostate cancer, in particular zoledronic and Docetaxel. So we set about designing a trial in newly diagnosed men with high-risk prostate cancer. The snag was, when we came to look at what agents were out there, there wasn't a clear single drug to do a trial with. So we decided that rather than just pick one at random, we would pick a number of different drugs to study.
Stampede is now the largest ever randomised controlled trial for men with prostate cancer. Right now, in August 2015, we're still recruiting to some of the comparisons, and more than 7,000 men have already joined the study. The men who are joining Stampede are those who are considered by their consultant to have high-risk prostate cancer. We've defined that as men whose disease has spread elsewhere beyond the prostate, or who have other high-risk features. What this group of men all have in common is that the consultant thinks that they should start long-term hormone therapy for the first time. The majority of men had newly diagnosed disease, but a small proportion, about 6 in every 100, had disease that has been treated previously with surgery or with radiotherapy and has now come back in a very aggressive form. Of all the men joining the trial, the average age is about 65, and about 6 in every 10 have distant spread.
When the Stampede trial started in 2005, it was testing 5 new ways of treating prostate cancer.
Stampede, over the years it's been running, has developed answers to quite a few different issues around the treatment of prostate cancer. And I think one of the most exciting has appeared very recently, which is the question as to whether a chemotherapy agent called Docetaxel should be used as part of the standard treatment for locally advanced prostate cancer, or for prostate cancer that's spread to other parts of the body or that's invaded the lymph nodes.
Docetaxel is a chemotherapy drug that works by stopping cancer cells dividing, so blocks the growth of the tumour. It was originally made from Nutri needles. Docetaxel is currently used for men whose tumours have stopped responding to hormone therapy. Stampede tested whether using it earlier, when men are just starting hormone therapy, could improve the current standard of care.
The standard of care for men joining the trial was long-term hormone therapy. In a small proportion of men, those whose disease had not spread elsewhere, they're encouraged to have radiotherapy to the prostate as well. All of the men joining the trial had that same standard of care. In the Docetaxel group, those men also received Docetaxel chemotherapy. That was given as 6 cycles, 1 injection every 3 weeks for 6 cycles. The Docetaxel group includes about 1,800 men. That includes around 1,200 who were allocated to the control arm and about 600 who were allocated to the Docetaxel group. Our main question in the trial is to see whether life expectancy was increased in average in the groups that were allocated to research treatments. We're also interested to know whether the disease stayed away for longer. We're interested in side effects. We're interested in the patient experience, patient-reported outcomes, sometimes called quality of life. And we're also interested in cost effectiveness.
What we showed in Stampede was that giving 6 lots of treatments, the same schedule, 3 weeks apart, resulted in a survival gain across the whole trial of around 10 months. And for the men with the worst disease, the disease that had spread at diagnosis, that survival advantage was 16 months.
So, Docetaxel increases life expectancy for men with prostate cancer, but it also increases side effects.
You get problems like nausea and vomiting, but that's actually quite easily preventable by giving prophylactic anti-sickness medicines. The second side effect, which again is common to all chemotherapy drugs, is that you affect other fast-dividing tissues. So this is things like any moist surface, so lining of the mouth, the gut, so you can get mouth ulcers, diarrhea, things like that, and also sometimes sore eyes because the eye linings are moist. The third thing, again common to all chemotherapy, is that the white blood cells are rapidly dividing, and a particular subset of white blood cells called neutrophils are vulnerable to chemotherapy. During the period where the white cells are low, patients are vulnerable to infections. What we found in Stampede was that overall about 10% of men got problems with infections at some point in the 6 cycles of treatment. So in other words, 90%, although their white cells dropped, didn't actually pick up an infection. For trial purposes, we grade on a scale that goes from 0, which is no side effects, through to 5, which is lethal side effects, which thankfully were very rare. Around in the control arm, the patients getting the standard treatment, around 30% of them reported grade 3 to 5 side effects. So that's significantly interfering with their quality of life. Now, a lot of these side effects will actually be not side effects of the treatment, but side effects of the disease. So it's hard to disentangle the two. That went up to about half of the men on chemotherapy in the 2 chemotherapy arms. And the bulk of the difference between the standard arm and the experimental arm related to men picking up some sort of infectious complication of the chemotherapy.
When you have chemotherapy, there isn't any problem. It's just like having a blood test because it's just a drip into your vein. There's no pain, there's no hassle. I didn't feel sick, which I expected to. I had a bit of pain in my bone and started to get sores. My hair started to come out after about 10 days, but it's all bearable. And if you can always think, well, if I'm suffering a little bit, then the guys down there are as well. So you can get some bonus psychologically from it, really.
So, how do the results from Stampede fit with the results from other trials looking at docetaxel for men who are starting long-term hormone therapy for the first time?
We looked at the results of the Stampede trial alongside other similar trials that have been published, and we then included all of these results in a piece of research called a meta-analysis. So for men whose disease has spread to other parts of their body, docetaxel improves life expectancy. At this point, we've got data on nearly all of those men whose disease had spread that were included in trials similar to Stampede, so we can be confident that these results are reliable. For those men whose disease has not spread, the results are less clear. There is a suggestion of a benefit of docetaxel, but at this point in time, there's not enough information for these results to be reliable. We'll need to wait for more data to be collected and more trials to be reported, and then we can look at this question again in the future.
The second comparison in Stampede looked at whether adding the drug zoledronic acid to standard treatment improves life expectancy compared to standard treatment alone.
So zoledronic acid is from a family of drugs called bisphosphonates. So these drugs were developed initially to treat osteoporosis, thinning of the bones. Research carried out quite some while ago, 10, 20 years ago, showed that these drugs, because they harden the bones, actually make it harder for cancers that spread to the bone to grow in bones.
Like for the docetaxel comparison, we had about 600 men who joined the zoledronic acid group and 1,200 men who'd been allocated to the control arm. We found no good evidence that giving zoledronic acid improved life expectancy in this group of men, nor did we find any increase in the time spent without disease.
The third comparison in the trial looked at whether a combination of both docetaxel and zoledronic acid, in addition to standard treatment, was beneficial for men with prostate cancer.
On average, the group that received both docetaxel and zoledronic acid had a better life expectancy than the group who were allocated to just the standard of care. Unfortunately, the improvement that we saw was no better than the improvement that we saw with just adding docetaxel. So we don't have any good evidence that adding zoledronic acid provided any improvement compared to adding just docetaxel.
So, Stampede has shown that docetaxel improves life expectancy for men whose prostate cancer has spread. What did these results mean for how men with prostate cancer should be treated?
So the recommendation we're making for men with disease that spread at the time of diagnosis is that they should be offered 6 cycles of chemotherapy alongside their standard hormone therapy. This is obviously for men who are fit enough to receive chemotherapy.
For men whose disease had not spread elsewhere at that point of starting hormone therapy, we think the chemotherapy could be considered in some cases because of the other advantages that we have observed.
The docetaxel results are very important and very exciting, and I guess the test for most trials and trial results is, do they change clinical practice? And I think the docetaxel combination with hormone therapy is very likely to change clinical practice. So it clearly is an outstanding result. With any prostate cancer treatment, there is always a trade-off between the benefits, which one hopes to get, and the side effects. And there are side effects from almost every treatment and every drug. And in the case of docetaxel, we know the benefit is now clearly demonstrated as a significant increase in survival, life expectancy. The trade-off is having the docetaxel chemotherapy, which can produce, for some men, some adverse effects. So I guess for each man and his doctor, it's got to be a decision. Is the benefit worth the trade-off?
There wasn't any contest as far as I was concerned, because when I heard the results of Professor James's work, I was just so pleased to think that there was somebody could knock this thing, which I didn't want and I wanted really to get rid of but couldn't, and that I could get extra life out of that. It was a real no-brainer.
Well, in some senses, it's the biggest step forward in systemic therapy since the 1940s. And really, there's been no change to the first-line drug treatment since then. So it's a pretty big advance.
There's a basic, really in the back of my mind, the feeling that if it came back, well, I'm just really put my affairs in order and prepared to turn up my toes. But this gives me hope. So from a personal point of view, I think it's very, very important. And I think this feeling of optimism is something that we shared around the community of those of us who have had or who have prostate cancer.
It means a lot for me, and also it means a lot for my family, because my family who don't have to suffer the side effects of chemo, which, as I say, is no problem for me anyway, but they also have the hope that I'm going to be around for a bit longer. And I've got grandchildren and children who are grown. My son and my daughter are in their late 40s, so, but their families are so pleased, and it's a relief for everybody to think that we're now on a path which has got hope, whereas before it just seemed we were on a path where we were running out. So, as I say, it is a big, big plus for me.
We now have results from some of the original comparisons in the Stampede trial, but there are still a number of other promising new treatment approaches currently being tested that may help to further improve outcomes for men with prostate cancer.
The set of results that have just been published are from the early arms that were set up in the trial. There are a number of arms ongoing, so the message, I think, for patients is please keep recruiting and volunteering to join the trial.
Taking part in a trial is always a nerve-wracking event because you know that you're out on a limb slightly. You're never quite sure what's going to be the effect. Are you going to benefit from the treatment? Are you not? Is the treatment going to have negative consequences for you? One thing I'd like to say to the patients that have taken part in Stampede is thank you. They're pioneers. And the rest of us, I think, should be eternally grateful for those who are pioneers who come forward, sometimes because they feel that they have no choice, they've run out of other options, but they still do it. They go into the unknown, and the rest of us will benefit from their experience.
Thanks to the thousands of men who have taken part in Stampede, we now know much more about how to treat prostate cancer. These results will have a big impact for the hundreds of thousands of men diagnosed with prostate cancer each year.
Obviously, you can quote the raw numbers. It's a big gain. It's probably one of the biggest gains seen in a single trial in terms of overall survival, so that speaks for itself. But it comes down to a personal thing as well, and one of the statisticians from the National Cancer Institute of Canada made the comment that thanks to these data, there'll be men dancing at their daughters' weddings who wouldn't otherwise have been there.